Today we will discuss anti-Parkinsonian drug. The drugs which are used in Parkinson disease are divided into two classes. The first one is the drugs which influence the dopaminergic system, and the second one is the drugs which influence the cholinergic system. The drugs which influence our dopaminergic system are divided into five classes. The first one is a dopamine precursor, which include the levodopa. The second one is a dopamine agonist, which include the bromocriptine, pramipixole, and ropinirole. The third one is an NMDA receptor antagonist, which include amantadine. The fourth one is an MAOB inhibitor, which include the siligeline and rasagiline. And the fifth one is a COMT inhibitor, which include a tolcapone and entacapone. All of these drugs will increase the level of a dopamine, so it will influence a brain dopaminergic system. The second one is the drugs which influence the cholinergic system consist of further two classes. The first one is a centrally acting anticholinergic drugs. These include a benztropine, benzhexol, procyclidine and bipyridine. And the second one is an antihistaminic with anticholinergic activity. It includes the promethazine, diphenhydramine and orphanadrine. So all of these drugs will decrease the level of acetylcholine. We will discuss all of these classes of drugs in detail, but before that let's study the pharmacological basis of these drugs. In human brain, there is a balance of activity in dopamine and acetylcholine. So whenever there is a loss of dopaminergic neuron in Parkinson disease, there will be an underactivity of a dopamine and overactivity of an acetylcholine. So to treat Parkinson disease, we have to increase the level of dopamine or we have to decrease the level of an acetylcholine. So that is why we use dopaminergic drugs and anticholinergic drug in Parkinson disease. Now let's begin with dopaminergic drugs in Parkinson disease. The first one is a dopamine precursor, levodopa. The levodopa is a first line drug in the treatment of Parkinson disease. We use levodopa instead of a dopamine because the levodopa can cross the blood-brain barrier while the dopamine cannot cross the blood-brain barrier. The levodopa is given orally 30 to 60 minutes before meal and it is absorbed in GIT from small intestine through active transport. When the levodopa is absorbed, it will work centrally as well as peripherally. Centrally, it will convert into a dopamine by an enzyme dopa decarboxylase. This dopamine will act on a D2 receptor in basal ganglia and will treat the clinical feature of Parkinsonism such as tremor, rigidity, bradykinesia and postural hypotension. The levodopa also act peripherally, but remember that only 2% of levodopa cross the blood-brain barrier. About 98% of the levodopa work peripherally. Peripherally, the levodopa is converted into a dopamine by the peripheral dopa decarboxylase. This dopamine will act on D2 receptor in chemoreceptor trigger zone, causing nausea, vomiting. It will act on a heart, causing tachycardia and palpitation, and it will act on a blood vessel, causing postural hypotension. So it will cause a wide variety of adverse effect. So to prevent this peripheral adverse effect, we use a combination of a levodopa with peripheral dopa decarboxylase inhibitor such as carbidopa and benserazide. These drugs will inhibit the peripheral dopa decarboxylase and will increase the central bioavailability of levodopa. So by using this combination, we can increase a central bioavailability along with decreased peripheral side effect. Commercially, the levodopa and carbidopa are present in combinations such as in a ratio of 4:1 or 10:1. After dopamine precursor, the second class of drugs is dopamine receptor agonist. It includes a bromocriptine, ropinirole and a pramipixole. These drugs are also given orally. It have a same mechanism of action as levodopa, but it has a longer duration of action. In this class, the bromocriptine is an ergot derivative. It has an agonistic action on D2 and partial agonistic action on D1 receptor. The bromocriptine is not widely used because it causes severe side effects such as a constipation, postural hypotension, cardiac arrhythmia, and digital vasospasm. So it is contraindicated in a patient with a history of mental illness, recent MI, peptic ulcer, and the peripheral vascular disease. While the ropinirole and the pramipixole are non-ergot derivative and they are more safer than bromocriptine. After the dopamine receptor agonist, the third class of drugs include a COMT inhibitor. The COMT inhibitor include a tolcapone and the entacapone. These drugs inhibit an enzyme COMT, the catechol O-methyl transferase enzyme. So by inhibiting this enzyme, it decreases the degradation of dopamine, so it will increase the lifespan of a dopamine. In these drugs, the tolcapone act both centrally and the peripherally, while the entacapone work only peripherally. These are safer drugs, but the tolcapone can cause a hepatotoxicity. For this reason, the tolcapone are contraindicated in a patient with liver disease. After COMT inhibitor, the fourth class of a drug include the MAOB inhibitor. The MAOB inhibitors include the salicyline and the rasagiline. These enzymes selectively and irreversibly inhibit the MAOB enzyme. The MAOB enzyme is an enzyme present centrally and it degrades the dopamine into its toxic metabolite. So by inhibiting the MAOB enzyme, we decrease the formation of a toxic metabolite, so it will cause a neuroprotective effect in Parkinson disease along with the decreased progression of disease. Among MAOB inhibitor, the rasagiline is more potent and longer acting than salicyline, and it is given as a daily dose. And the side effect of these drugs include insomnia, anxiety, and vomiting, because the salicyline are converted into its metabolites such as amphetamine and methamphetamine, and it can cause side effects such as insomnia, anxiety, nausea, and vomiting. It was all about the MAOB inhibitor, but students often confuse the mechanism of action of COMT and MAOB enzyme. So to have a clear concept about it, let's review the mechanism of action of MAO and COMT inhibitor. Whenever we give levodopa, the levodopa will act both centrally and peripherally. Centrally, the levodopa will be converted into a dopamine by an enzyme decarboxylase. This dopamine will produce anti-Parkinson effect, and after that it will get degraded. The degradation of this dopamine will occur through two pathways. The first one is that the dopamine will be converted into a DOPAC, the dihydroxyphenyl acetic acid, by an enzyme MAOB, while this dopamine will get degraded into another product such as a 3-MT, the 3-methoxytyramine, by an enzyme COMT. So the MAOB inhibitors such as a salicyline and the rasagiline act on the MAOB and it will inhibit the degradation of a dopamine, while the central acting COMT inhibitor such as a tolcapone will act on this COMT enzyme and will prevent the degradation of dopamine. So this is how the MAOB and the central acting COMT inhibitor act. While in periphery, the levodopa will convert it into a dopamine by an enzyme decarboxylase, while the levodopa will also convert it into a 3-OMD. The 3-OMD means the 3-O-methyl dopa. So this conversion is under the control of an enzyme COMT. So the COMT inhibitors such as a tolcapone and the entacapone will inhibit this enzyme and prevent the peripheral degradation of a dopamine. So by inhibiting the peripheral degradation, it will increase the central bioavailability of a levodopa. This is how the MAOB and the COMT inhibitor work. Now let's switch our gear toward the last class of drugs which influence the dopaminergic system is NMDA receptor antagonist. The NMDA receptor antagonist, which include an amantadine. The amantadine is an antiviral drug which is used for the treatment and prophylaxis of influenza A virus, but it is used in Parkinsonism. How it help in Parkinsonism? It works through two mechanisms. The first one is that it facilitates the synthesis and release of dopamine from a dopaminergic neuron in brain, and the second one is that It decreased the glutamate neurotransmission in basal ganglia, which contribute to the beneficial effect in Parkinsonism. This NMDA receptor antagonists are used in mild cases, and it is usually used in combination with levodopa. The side effects of an amantadine include constipation, nausea, vomiting, hypotension, hallucination, and livedo reticularis. The livedo reticularis is discolored patches on skin. So it was all about the anti-Parkinson drug which influence the dopaminergic system. Now let's switch our gear toward the second class of anti-Parkinson drugs which influence the cholinergic system. The drugs which influence the cholinergic system include two classes of drug. The first one is the central anticholinergics, and the second one is an antihistaminic with anticholinergic activity. So the central acting anticholinergic include a benzhexol and benztropine. These drugs are the drugs of choice for drug-induced Parkinsonism. They have mainly central action, it have a little or no peripheral action, and it act by reducing the level of acetylcholine. By decreasing the level of acetylcholine, these drugs help in relieving the tremor and rigidity, while these drugs have a little effect on hypokinesia. So these are mostly used in drug-induced Parkinsonism. The side effect of the central anticholinergics include dry mouth, confusion, constipation, blurring of vision, and hallucination. The second drugs which influence the cholinergic system is antihistaminic with anticholinergic effect. It include a promethazine, diphenhydramine, and orphanedrine. These drugs also act centrally and help in a Parkinsonism. These drugs are also used in drug-induced Parkinsonism. So it was all about the anti-Parkinsonian drugs or the drug used in Parkinsonism. If there is still any question, you guys can ask, and stay tuned for more update.